The objective of this lecture, you must know what are the type of different movement disorders, what is Parkinsonism and its different type, and also you must learn how to diagnose and treat Parkinson's disease, what is the tremor and its different types, and you will be able to diagnose and treat of essential tremor, and also you must differentiate between Parkinsonian tremor from essential tremor. The movement disorder is due to impairment of voluntary motor activity without affecting strength, sensory, and cerebellar function. And it includes two types: the hypokinetic type, which is characterized by poverty of movement, like Parkinson's disease, while the other type is hyperkinetic movement disorder, which is characterized by excess of movement, like tremor, chorea, dystonia, athetosis, palismos, myoclonus, and tic. This slide shows you the composition of extrapyramidal system, which is important in the abnormal movement disorders, and it's composed of eight parts: premotor area, caudate nucleus, lentiform nucleus, subthalamic nucleus, radionucleus, substantia nigra, inferior olivary nucleus, and reticular formation. So, now what is Parkinsonism? It is a tent of a group of different neurological disorders that cause movement problem which are similar to the Parkinson disease symptoms. As you see in this slide, the classification of Parkinsonism, it includes different types. As I said, it is a tent. The first type is idiopathic Parkinsonism, which is Parkinson disease, atypical Parkinsonism, and previously this atypical Parkinsonism called Parkinson plus syndrome, and includes multiple system atrophy, progressive supranuclear palsy, corticobasal ganglionic degeneration syndrome. The third type is hereditary Parkinsonism, and the fourth is secondary Parkinsonism, which include different causes such like drugs, which include antipsychotic drug, calcium channel blocker, lithium, antiemetic, and stimulant like amphetamine and cocaine. Vascular Parkinsonism due to multiple infarction or infarction in the basal ganglia, infections, toxin like MPTP, manganese, carbon monoxide, carbon disulfide, cyanide, methanol, and hexane. Traumatic cause for Parkinsonism, and lastly, metabolic cause like hypoparathyroidism, non-Wilsonian hepatocellular degeneration. What are the components of basal ganglia? It composed of caudate, putamen, lobus pallidus, substantia nigra, subthalamic nucleus, and the term striatum referred to caudate and putamen, and the term lentiform nucleus referred to putamen and the globus pallidus. As you see, substantia nigra, it's a part of basal ganglia. It is an important part of basal ganglia because it composes the base of pathophysiological Parkinson disease, and it consists of two parts, pars compacta and pars reticularis. As you know, Parkinson disease is the second most progressive neurodegenerative disease after Alzheimer, and typically it affects 1% of population older than 60 years of age and 1.5% of population older than 70 years of age, and men carry a greater chance of having Parkinson's disease than women. In this slide, I show you the history and background of Parkinson's disease. The English physician James Parkinson first characterized Parkinson's disease in 1917 in his 1917 monograph, An Essay on the Shaking Palsy. He described people who presented with resting tremor and shuffling gait, stop posture, sleep problem, and constipation. And he called it at that time paralysis agitans. Later, at 1861, Charcot later add bradykinesia and rigidity to the symptoms and renamed the condition as Parkinson's disease. At 1880, Gowers identified the men were more prone to the disease than women. The pathology of Parkinson's disease is due to loss of the darkly pigmented area in substantia nigra pars compacta and locus ceruleus. This pigmentation loss directly correlates with the death of dopaminergic neuron in the substantia nigra pars compacta and non-adrenergic neuron in the locus ceruleus. The cell death in the substantia nigra is mostly restricted to a specific group of neuron melanin containing dopaminergic neuron, while other neuronal and glial cells type are spared. The motor symptom of Parkinson's disease become evident when 60 to 80% of dopamine neurons are lost. As I said, Parkinson's disease is a progressive neurodegenerative disease of multifactorial etiology. The environmental and behavioral factors seem to modify the risk of developing of Parkinson's disease. Some of these factors are increased the risk of Parkinson's disease as exposure to pesticide, consumption of dairy product, history of melanoma and traumatic brain injury, while other factors are reduced the risk of Parkinson's disease like smoking, caffeine consumption, high serum urate concentration, physical activity, and the use of ibuprofen. This slide show you the classic cardinal features or cardinal symptoms of Parkinson's disease, which includes resting tremor or tremor at rest with frequency of 4 to 6 Hz, and this tremor rhythmic oscillation around a fixed point in the wrist or non-postural position, as it is named resting tremor. Second, rigidity, typically cogwheel rigidity, which is felt at the wrist joint. The other cardinal features, slowness of movement or bradykinesia, which are characteristic of all Parkinson patients. Postural instability, and this is occur at the late stage of disease. The asymmetry, which is apparent in 75% of patients at presentation. All these are the cardinal features of Parkinson's disease. This slide shows you other motor features. As you know, the Parkinson's disease have a motor symptoms and non-motor symptoms. And then this is other motor features or symptoms like micrographia, mask faces, hypomimia, reduced eye blinking, hypophonia, dysphagia, freezing, loss of arm swinging, flex posture, shuffling, and fastened gait. This is the non-motor symptom and which composed of cognitive, autonomic, and sensory manifestation for Parkinson's disease. Till now, the diagnosis of Parkinson's disease is based on history and the clinical examination. There is no isolated lab test or neuroimaging to diagnose Parkinson's disease. So the United Kingdom Parkinson's Disease Society brain bank criteria is the practical gold standard for the diagnosis of Parkinson's disease based on essential clinical findings as well as supportive and exclusion criteria for diagnosis of Parkinson's disease. And as you see in this slide, the United Kingdom Parkinson's Disease Society brain bank criteria It is composed of three steps. The first step is based on the bradykinesia, the presence of bradykinesia, which is the most important cardinal features for Parkinson's disease, plus at least one of the following, either cogwheel rigidity, resting tremor, or postural instability. The step two is exclusion criteria of Parkinson's disease, or as they call it, the red flag for Parkinson's disease diagnosis. So in this step, you must exclude or secondary causes for Parkinsonism, like repeated head injury, repeated stroke, infection, drugs causes, and so on. The third step is supportive for the diagnosis of idiopathic Parkinson's disease, and it includes the unilateral onset of the disease, the resting tremor presentation, progressive disorders, persistent asymmetry affecting side of onset most, excellent response to levodopa, and 70 to 100% of patients with Parkinson's disease have good response to the levodopa treatment. Levodopa response for 5 years or more, and the clinical courses of 10 years or more. As we said previously, the diagnosis of Parkinson's disease based on the history and the clinical examination. So it may be a complex, and it is estimated that approximately 25% of patients have been misdiagnosed with another disease. The differential diagnosis of Parkinson's disease include tremor syndrome, such as essential tremor, atypical Parkinsonism, as well as secondary Parkinsonism, and other cognitive disorders such as dementia with Lewy body and Huntington disease, normal pressure hydrocephalus, and Wilson disease. The treatment of Parkinson's disease. The goal for the treatment of Parkinson's disease, the main goal is to prevention the disease progression, and as you know, there is no drug modifying therapy for Parkinson's disease. All the drugs available in the market is asymptomatic treatment for motor symptoms and non-motor symptoms. So the goal of your treatment for Parkinson's disease in the world is to prevent the disease progression, symptomatic treatment for motor symptom, and management of motor complication as it occur later in the disease, symptomatic treatment of non-motor symptoms. This is the categories of pharmacological treatment for Parkinson's disease. The major drug that available for symptomatic treatment of motor symptoms, and the main cornerstone is till now is the levodopa for the treatment of motor symptoms of Parkinson's disease, MAO-B inhibitors, dopamine agonist, and catechol or methyltransferase inhibitor, anticholinergic, and lastly amantadine. The carbidopa-levodopa, as I said, is still the most potent and effective symptomatic treatment for Parkinson's disease and remain the gold standard. And the carbidopa-levodopa are available in different formulations as Sinemet regular release, control release, or oral disintegrating tablet, Parcoba, and this for if patient have difficulty in swallowing in the advanced stage of Parkinson's disease, so we give the patient oral disintegrated tab, intestinal infusion Diopa, which and have Ritter formulation, and extended release carbidopa and levodopa treatment to avoid the motor complication of Parkinson's disease. The treatment of motor complication is complex. After the motor complication or fluctuation may develop during the course of the disease, at 3 to 5 years from the onset of disease, and it either due to a progression of disease or due to as a side effect of L-DOPA, and it is either dyskinesia, which is involuntary excessive coriform movement, or dystonia, dystonic posture of the big toe and foot, and the treatment of this complication is either to increase the frequency of dose of the L-DOPA or maintain the L-DOPA and add dopamine agonist, add COMT inhibitor, add MAO-B inhibitor. If this not benefit for the patient, so we shift the patient for surgery and do to the patient deep brain stimulation or continuous infusion of carbidopa levodopa therapy. Dopamine agonist, another category for the treatment of motor symptom of Parkinson disease, and they are available as pramipexole, ropinirole, rotigotine patch. The adverse effect: nausea, somnolence, peripheral edema, hallucination, postural hypotension. Other category, amantadine, is have modest symptomatic benefit in tremor and rigidity and bradykinesia. The amantadine is effective for the levodopa-induced dyskinesia, and it is adverse effect cognitive effect, mild anticholinergic effect, leg swelling, livedo reticularis, and hallucination. MAO-B inhibitor may also help early in the disease to improve symptoms and certain if the medication slows the progression of the disease. They are usually used in combination with other Parkinson's disease like levodopa and is available as siligilene 5 mg twice a day dosing or rasagiline 1 mg once a day dosing. Safinamide or Xadago 50 mg tab. This is a new drug and it is a new third generation MAO-B inhibitor recently licensed for treatment of Parkinson's disease as add-on therapy and for the treatment of fluctuating Parkinson's disease patients. Start with 50 mg orally once a day. At the same time, after 2 weeks or 1 month, the dose may increase to 100 mg once a day according to the response of the patient. Anticholinergic mainly used in younger patients where tremor is the main problem and can also help in dystonia, but it had limited use because of side effects, especially in old patients above 60-65, and as you know, the incidence of Parkinson's disease increase after 60 years of age. COMT inhibitor, another category used for the treatment of Parkinson's disease. There is no rule for COMT inhibitor as monotherapy, only used in combination with the levodopa in form of Stalevo, a combination of carbidopa, levodopa, and entacapone, which is COMT inhibitor. If the patient in advanced stage refractory for medical treatment to control the motor symptoms of Parkinson's disease, so we prepare the patient for surgical treatment. And the procedure for surgical treatment for Parkinson's disease called deep brain stimulation, which is a surgical procedure used to treat several disabling neurological symptoms. And as you see in the picture, there is a pulse generator in the chest and lead which connecting to the electrode, and the electrode is implanted in the subthalamic nucleus of the basal ganglia, which is the main target for the Parkinson's disease treatment. Treatment of non-motor symptoms in this slide and the other slide, treatment of different symptomatic treatment of different non-motor symptoms like pain, constipation, dementia, depression, gambling, and other orthostatic hypotension. We give recently droxidopa, which is oral norepinephrine precursor, 100 milligram 3 times a day, avoiding 3 hours prior to bedtime to reduce supine hypertension, and treatment of sialorrhea, which is best treatment botulinum toxin, intraglandular, sleep disorder, insomnia, melatonin, excessive day sleepiness, and sudden onset sleep, which is treated by modafinil. So, what's a tremor? Tremor is rhythmic oscillation of body part. Is among the most common involuntary movement. The most common cause of a tremor is essential tremor. Concentrate on this. The most common cause of a tremor is essential tremor. The essential tremor is the most common involuntary movement disorder, and the tremor is classified into resting tremor or action tremor, which include postural, intention, or rubral tremor, and the rubral tremor is due to lesion of radionucleus, and the other type of tremor is myasthenia, psychogenic tremor, orthostatic tremor, or dystonic tremor, and all these tremor have multiple causes. This video shows you the rubral tremor in patient with lesion to the radionucleus. And this slide
This
shows you
patient
the
exhibits an
typical
irregular and
resting
large
tremor in
amplitude
patient
tremor
with
of her right hand
Parkinson's
and
disease.
fingers, which is present at rest, while her hand is in various postures and during action.
Okay, can you count 1 to 10 for me, please?
The amplitude as well as the frequency of the tremor are variable, and sometimes the tremor spontaneously ceases for a second or two.
What seems to be the problem?
My hand shakes. It stops, and since I had this, I know what I want to say, and I stutter, and my hand shakes.
Okay.
And I lost a little weakness in my leg on the right
Okay.
side.
How long has it been going on?
I had it August the 4th. It's gotten a little bit better because my hand just stays right here. Before, it was flying all over.
I see. Okay. Can you do a few things for me? Put both hands in front of you. Okay. Try to spread your finger out as much as you can. Okay. Now can you do like this for me, please? Okay. Now can you do like this for me? Both sides, both arms. Okay, put it in front of you again. Okay, with your left hand.
The tremor also ceases in her right hand when she's asked to carry out repetitive movements of the left hand. Slow repetitive movements of the left hand are associated with entrainment in the right hand, whereby the frequency of the right hand becomes similar to that of the voluntary movements of the left hand.
The right hand? With the right hand.
Okay. Okay, put both arms down. Your hands, please. Okay. Walk with me. Okay. You do it one more time, please. Put your hands down, please. Okay, turn around and do it one more time.
This slide shows what is dystonic tremor. One important type of postural tremor or action tremor is enhanced physiological tremor, and this type of tremor is commonly seen in clinical practice. The cause of this type of tremor: stress, fear, and anxiety. Some type of drugs like beta agonists, tricyclic antidepressant, theophylline, caffeine, sodium valproate, anti-epileptic drug can cause this physiological tremor. Toxin, mercury, lead, arsenic, carbon monoxide, endocrine cause like hypoglycemia, thyrotoxicosis, pheochromocytoma, and excessive physical activity and sleep deprivation that also cause enhanced physiological tremor or postural tremor. Essential tremor. It is important for you in a clinical practice to differentiate between Parkinsonian tremor and essential tremor. So, the essential tremor is most common involuntary movement disorder, as we say. Approximately 50% of cases have positive family history. So if the patient have positive family history, you must look for exclusion of essential tremor with an essential tremor with an autosomal dominant pattern of inheritance. The prevalence increases over the age of 70 and is characterized by high frequency tremor 8 to 12, about 8 to 12, not 4 to 12. And while the Parkinsonian tremor 4 to 6, and it is dominantly affect the upper limb and is most prominent when trying to maintain a posture. So it is postural, but while Parkinson's disease is resting tremor. The tremor typically bilateral symmetric, while in patient with Parkinsonian tremor is asymmetrical, but one side can be predominantly affected. The tremor may affect the head, while the Parkinsonian tremor affect the jaw, while the tremor of essential tremor may affect the head and the speech. The tremor characteristically improve with alcohol and may be worsened with stress, while Parkinsonian tremor not improve with alcohol, only improve with levodopa. The diagnosis of essential tremor. The core criteria: bilateral action tremor of the hand and forearm, absence of other neurological sign. So in the Parkinsonian tremor, after a neurological examination, we found rigidity, bradykinesia, multiple motor and non-motor symptoms, while in essential tremor, the neurological examination normal and may have isolated head tremor. Secondary criteria: it's of longer duration, more than 3 years. Positive family history, as we said, is autosomal dominant. Beneficial response to alcohol. This is the criteria for diagnosis of essential tremor. And this slide shows you typical patient with essential tremor.
You? Okay, now up under your nose, but don't touch.
Both?
Both hands, yep. Try not to touch, that's good. Okay, goes
Okay.
backwards and forwards. Okay, in this hand.
The left hand were
Okay, take it with both.
There's no way I can do it.
Okay. Ah.
The treatment for essential tremor is medical treatment and surgical treatment in refractory tremor. And the main standard treatment for essential tremor, propranolol, and we get response, patient get response with optimal response in 240 milligram to 320 milligram of propranolol. Second drug, primidone, its limited effect because of its side effect. It causes severe sedation, and it should be started 25 milligram at bedtime with doses above 250 milligram to 350 milligram are rarely needed because of severe sedation. The third drug used, topiramate, have suggested in some studies to improve in the of essential tremor. Surgical treatment, the same procedure is deep brain stimulation for the surgical treatment of Parkinson's disease and essential tremor. But the differentiated between these, the target in the Parkinson's disease is either subthalamic nucleus in patient predominantly with tremor or globus pallidus in patient predominantly rigidity, while in essential tremor, the main target for the DBS is ventral intermediate nucleus of thalamus. Thank you.